Welcome, everyone. Thank you for joining us for the webinar, The Future of Hypertension Care, Integrating the Cuffless ABPM Solution into Practice. Presented with Dr. Maria Delgado Lelievre, founder and director of the AHA Certified Comprehensive Hypertension Center at the University of Miami. Next slide. Dr. Delgado is the assistant professor of medicine and the AHA hypertension specialist, founding director of the AHA Certified Hypertension Center at University of Miami. Dr. Delgado was a recipient of the AHA Samuel L. Levine Young Clinical Investigator Award, the AHA Women in Cardiology Award, the American Society of Hypertension Recognition Award for Young Investigator, the National Institute Health Biomarkers and Surrogate Endpoints Award, among others. Dr. Delgado has several publications, book chapters, and peer-reviewed publications in the field of hypertension and cardiovascular disease, with extensive experience in clinical, epidemiological, and bench research in the field of hypertension. My name is Jay Heimsoth, the director of Biobeat. Have years of experience in medical device sales, sales leadership, health economics, multiple startups, launching new disruptive technologies. Next slide. So I think it's important to understand why this is a valuable webinar and why we're coming together tonight. Hypertension, obviously, we know has a high prevalence, but more importantly, 1 in 4 patients have uncontrolled hypertension, highlighting a critical health challenge. There's also a lack of 24-hour blood pressure data. This prevents optimal understanding and control of the condition. Also, 24-hour ambulatory blood pressure has been essentially understood as the gold standard for assessing true control. But the issue is less than 10% of the patients have access to such a diagnostic test, which is a significant gap in care today. That limited access impedes accurate diagnosis and effective treatment. Next slide. So this is where I'll hand it off to Dr. Delgado, the future of hypertension care and integrating an FDA-cleared cuffless ABPM solution into practice.
Good afternoon, good evening, everybody. First of all, happy Memorial Day to everybody and those who are serving in the militaries here and abroad. My respect. I'm a mom of a Navy guy, so I know what it is. So I'm very happy to be here because this is an extraordinary technology for clinical use on daily basis on the real world that help us understand what is hypertension, what are our patients doing, and how that variability of blood pressure, which is the ABPM that we know, can help us understand, diagnose, treat, and monitor hypertension. Next slide. So it's not it's well known basically in former and current hypertension guidelines, both for the United States, Europe, Asia, and Latin American hypertension guidelines. Everybody actually is in accord that ABPM, or ambulatory blood pressure monitor, is essential for understanding, for diagnosis of hypertension. And basically, when you make the diagnosis, when you understand, because the diagnosis of hypertension is extraordinary dynamic, right? It's not just one reading, it's what's happening with the patient's life. So blood pressure is actually the pulse of life. That's what it is. We have pressure because we're alive. So that changes with what we do. So seeing that and being able to look at average during the day and night on a clinical basis is extraordinarily useful to manage patients. And that's very well understood from any of the societies, but especially the ACC, American Heart 2017 guidelines for hypertension. So, okay, let's go to the next slide. In the United States particularly, the problem that we have with everybody knows ABPMs are important. that we need to establish a 24-hour blood pressure monitoring for a patient. However, still like something very isolated. We do it only on very few patients, and the ability to repeat it is almost none. Do that is actually a device where you're putting on the patient, right? So it had to do more about the clinic or the hospital have to acquire devices that it's a device with a cuff, the patient have to wear it. And that alone, especially in the United States, has been a big problem. So most of the clinics, the regular clinics, do not have it. The hypertension clinic have two or three, especially if they're big, but that's about it in numbers. Your hypertensive population is tremendous, right? It's the most common cardiovascular disease worldwide. So being able to do one ABPM in a population of 100 patients per week or per every 2 weeks on a clinical setting is very extraordinary in the sense that you're going to miss a lot of data that will help you treat hypertension, which we all know the big problem that we have is we're still missing. We're still one out of four is control. We have a lot of patients are uncontrolled on daily basis that we see. So we're missing a huge window of opportunity where if we do ABPM on the real world on all our patients, then you're going to see patterns of treatment that are very important to address. You're going to see patterns of behavior during the day and night that you need to look at in order to talk to your patient, tell them where the blood pressure what the blood pressure is telling you. Look, it's uncontrolled during the night. What's going on during the night? Are you sleeping? Is it a sleep apnea? Are you working at night? So there's a lot of information that when you put it together will help you treat the patient. So one of the things that let's continue with the other slide. So those who knows what a traditional ABPM is will know that is, and if you ever had one on, is actually a device with a cuff. So as you can see, you have to go to the clinic. We need to have one available for you that day for your patient. The nurse will attach the cuff and the device usually goes around your, sometimes hooked to your pants or any part of your garment. As you see, the cuff goes through your back. So usually we ask a patient to bring a jacket or something to put on so it's not noticeable because they don't like to walk around with this. And then they have to wear the device for 24 hours. As you know, part of measuring variability of blood pressure has to do with be natural, do what you normally do during the day. So almost 100% of the patients, when they're wearing a cuff, they will stop when they know the blood pressure is going to be measured. If they're walking, they stop. If they're talking, they don't talk. They get tense or they get relaxed, whichever pathway they're going to choose. But they actually, on purpose, preparing themselves for the blood pressure measurement. And that's just what they do on the regular 24 hours. Then they are at work or at school or at home. The noise, and everybody knows about it, that you're taking your blood pressure, and then we can forget about everything else. But the pain is actually one of the most uncomfortable things where patients actually complain about because it hurts having the cuff inflated. And obviously in a 24-hour period, you have a night, right? So the night means that you have to sleep with it. And that's another set of problem because how did you put the arm? What do I do if I want to take a shower before going to bed? In what window do I take it off and then put it back in? And these patients usually get a contract signed where they need to, make sure they understand they have to return the device and they can't break it. So next day, usually the patient comes, get the device unhooked, and then the data is downloaded, and then the cuff, particularly the cuff, have to be sterilized or disinfected. So that's the pathway. So I'm not talking about the device itself and how much it can cost to the clinic and how many of few of them are in clinic. We're talking about centers like, like mine, hypertension centers. They only have 3, 4, no more than that. I'm talking about what the patient feels, right? Next slide. So these are the basic, and that's why I know who knows about a traditional ABPM knows this. So it's very uncomfortable. It can cause pain. Um, the device awareness and the fact that you actually know when the blood pressure, it doesn't get you by surprise. You actually know when it's going to be inflated. You either get anxiety or you try to relax, not talk, not do anything so you don't affect your blood pressure. And again, you can't do what you normally do because you have something around your neck, on your arm, and it actually disturbs daily activity. And obviously, sleep is one of the things that most of the complaints goes around sleep. I can't sleep, doc. I don't want to use it anymore. And so when we lead to this, right, it's still it's a traditional ABPM and worldwide, and it's been used. It's just not as frequent as it should in the real world because of the reasons that I'm explaining. And it's specifically clear in the United States, it's just the amount of devices per clinic specialized in hypertension are very little. Not to say that regular cardiology or internal medicine clinic don't even bother, right? Because the cost and the patients complain, then nobody wants to wear this around. Next slide. So let me do a little parenthesis. So when we started the hypertension center was before we had access to the Biobeat technology. So when I started developing the clinic, there were about 2 traditional ABPM, and immediately I told them, listen, this is not going to work for me. We need to get more. So we got 2 more. So we were with 4. So it was really, really frustrating from my standpoint to try to assess patients because in a week we had 4 plays, and then we don't see this until next week. So there were a significant amount of patients that will not being able to get a ABPM at the right time, which is usually during the first week or so after the first visit for assessment. So in like a couple of years into the development of the center, we got access to the new technology of Biobeat that was already FDA approved. And in the way we work, we have a clinical director for all cardiology, and they wanted me actually to see what do I think about the technology, and it blew my mind that it was a patch. So now we're going from something you put in your arm to something you put on your chest. That was extraordinary. And throughout a significant back and forwards in terms of the technology, how is it measured, and even back then we went through a pilot. We actually established Biobeat in the clinic. So let me tell you the dimension. We basically on every single patient that have any complaint related to hypertension, meaning either hypertension or hypotension because the blood pressure is too low, down to the kids 18 and older that are at risk of hypertension, and parents or the kid themselves are concerned about developing hypertension. So it's very broad, the diagnosis. Every single patient on their first visit will have in order for a Biobeat. And these are, patients with insurance. These are not self-pay patients. These are patients that need to pay their copay when they come in, either Medicaid, commercial, or Medicare. There's no discrimination in that sense. A very broad population here in Miami, all the races, both from underserved community to to well patients, but they all have in common that they have insurance, they come to see us, and they get this assessment. So that was for us night and day, because you have the ability to look at blood pressure physiology in the closest to the unbiased measurement, right? Unbiased, why? Because when you know that your blood pressure is being measured, you're affecting that reading as well. The pain is affecting, you're thinking about it. This is something where you can't even think. So it's just, you put the patch, the patient goes home, and we tell them, do whatever you want to do. Of course, exercise and sweating is a big problem because the sweat can separate the patch from the skin. But other than that, everybody does whatever they normally do, and they can't control the fact that their blood pressure is being measured without their knowing when. So that's very, very, very particular. So you open a window where now your population of patients, you can see their blood pressure as it is. I call them virgin, right? Sometimes with no medication, you'll see what is their sympathetic tone during the day, how excited they are when they're working, walking, whatever they're doing. And then the nocturnal dipping that follows the circadian rhythm, that's the other story, right? How they sleep, whether they relax, do they have any indication of sleep apnea? Do they actually invert their circadian rhythm because they're working at night? You can actually see that and pinpoint that. But in terms of practical sense in clinic and for the patient as well for the provider is, what is your average? Where does your average fall during the day and during the night? And that's where you can tell how much of control do we have or not. And based on the physiology, you know, you can have an insight of what to do. So let's go to the next slide. So when we compare traditional ABPM pathway to the Cuffless ABPM pathway, things are a little bit different, right? So the patch comes in a little box. The patient comes to clinic. The patch is being placed by the nurse, and they actually download a mobile application on their phone. So this is a condition that is important. They need to have an intelligent phone that can do Bluetooth with the device, which is in our population about 95% of everybody has some sort of phone that have Bluetooth that can download an application. Patient goes their way, we explain to them, which they love. You do whatever you need to do. Don't sweat because it's gonna fall. We have to tell them that, although there is a group, you know, especially the young people, they're very high into prevention. They want to do everything. So we have to explain to them, be careful with the sweat. And then we tell them, listen, next day, when you complete the 24 hours, it's going to be over. You take it, or you take it off, you pull it off, and then you throw it away. So that for them and for even the physicians, it's fascinating because we're used to the fact that you have to bring it or send it or mail it. This is just throw it away. And directly the report is generated and then sent to us, right, to the provider. What I'm just telling you, right, I'm talking to you from the perspective of a hypertension center director, right, who runs a very big hypertensive clinic. What happened after a year is how it expanded to all the providers. So now the providers in cardiology, whether they're interventionists or not, are ordering Biobeat because they want to know. Internal medicine, which they have half of their population is hypertensive, now they're not afraid, they're not concerned about ordering an ABPM. So they order it. And nephrology, which only every now and then when there's a patient with severe end stage kidney disease and very uncontrolled hypertension, they will order an ABPM. Now they're doing it routinely. So knowledge kind of give you power, right? And that expands. So everybody wants to be part of that. Okay, I want to know also what's going on with my patient's blood pressure. And that's probably what is fascinating. We went from a world where only very few will get the ABPM order to a world where in a such common disease, almost everybody who comes with a problem related to hypertension, at least is eligible to get um, this monitor on. So that's the difference between traditional and the new pathway of cuffless ABPM. Next slide. Of course, as you can intuitively understand, um, cuffless ABPM patient experience is night and day. So patients are not aware. Obviously, there's no pain related to this. The connection is Bluetooth. So that's the one thing that they need to keep kind of their phone close to them all the time, which is not a problem in the younger population, but as people age, like in their 80s and 90s, because we do this on a very, very broad age, you know, they need to be reminded that you can't leave the phone on the table, you have to carry it with you. So we make recommendations like to carry a little bag if you need to keep your phone. Everybody else carry their phone 24/7 on their hand. And they know, or what is so interesting is that we tell them, listen, when you do this, we're going to get an insight of who you are, what is, why do I say who you are? Because it's actually part of who you are. The blood pressure is you responding to everything that lives around you and inside of you, right? And so they're very intrigued. They want to see it. When they see, it's actually kind of funny because many patients are able to see their report before they see me in clinic. And they will come very proud and tell me, I already saw my report, doctor. My blood pressure is very good. I'm very happy. I say, okay, you're gonna skip the visit this time. But that happens a lot. They can see, they know when you explain them, listen. One of the things that patients kind of very difficult for them to understand is variability. And I'm gonna just take 1 second. One time a lady like in her 80s, was very upset, and she tells me very kindly but angry, why, Dr. Delgado, you have to explain me why my blood pressure doesn't stay on one number. Why it move up and down? Why it's not 120/70 all the time? And this lady was 80-ish, so towards the end. And I told her, well, let me tell you something. Yeah, you could have a one single number, but that will happen when you're underground. So with death, and one single number happens. While you're alive, there's variability. So she laughed, of course, but that understanding the variability is part of life is important because patients get worked out about a single reading that they get at home, and worse, the doctors get work out of a single reading they get in the office. So they see somebody with 180/100, whereas their home blood pressure is 130/70. The 24-hour blood pressure monitor shows the similar average, but you respond to that 180. That is one of the windows are absolutely beautiful when you can say, hello, this is your sympathetic tone acting. This is not you. Your blood pressure is different. Continue what you're doing right now. And it's actually pretty good it's really truly fascinating the way it changed not only our clinic, but the others. So we're talking general cardiology, preventive cardiology, interventional cardiology, nephrology, and internal medicine. Next slide. So this is just to give you an example. And this is a very, very typical. So this is a patient that with uncontrolled hypertension, this will be the baseline blood pressure, right? So if you see the purple line, that's systolic blood pressure variability. The red line, interesting, as you can see, is the heart rate. So both systolic and heart rate has a kind of mirror imaging. Why? Because they're very responsive to sympathetic tone. The light blue is the diastolic. So this patient comes in, as you can see, the average is actually pretty high, 169/115. And then during the daytime, a mild dipping, but still pretty high, 152 over 111. So the beauty is to see, right, once you treat your patient, how does that blood pressure improve? So that's the power that you will have, that when you repeat the study, you can tell the patient, look what you did. This is what you did when you did the non-pharmacological intervention and with the medications that we change, right? So your approach to treating hypertension can be strongly validated when you are able to monitor blood pressure response to treatment. So you can see this patient, right? They're systolic during the daytime, went down about 20 millimeters of mercury, and the diastolic about 10, a little bit more than 10, and a significant reduction on nocturnal blood pressure with a nicer dipping that you can see here on the at the nighttime, where it went down probably 30 and for systolic, and about 30 also for diastolic. So this is actually very important to validate your treatment, and also for patients' satisfaction. And obviously what we want to do when we do when we do treatment and we can have evidence that the treatment work, is a reduction of outcomes or target organ damage related to hypertension. So this, what you're seeing in this very small example, is something very common. So you and all of you that manage hypertension, you give treatment and the patient will write their blood pressure at home, and somehow you have a sense whether the treatment work or not. But this is a very objective way for both the doctor and the patient to understand how the blood pressure improve. And interesting enough, and a common finding is in many patients that do their own blood pressure logging at home, because I never tell them to stop. Even with the Biobeat, I'll tell them, listen, log your blood pressure at home at least twice a day, 3 to 4 times a week. It doesn't have to be every day. When you look at the average that they get at home, it's actually similar to the average of the new 24-hour blood pressure monitor. So it's very interesting how they are very much correlated. And the response, again, and we all know that, the response to the blood pressure in office has no correlation with anything, not with a home, not with the ABPM. So this is actually what we do. We had done for the last year and a half or 2 years, over 2,000 readings. And everybody, as I say, there's no discrimination. Everybody that has any issue with blood pressure will get it. Autonomic dysfunction, for example, post-COVID syndrome, POTS, even though they're not hypertension, they are blood pressure dysregulation phenomena, and we put the order and they're covered. So anyway, now I'm gonna lead to Jay.
Thank you, Dr. Delgado. We really appreciate it. We'll have an opportunity to ask some questions after just a couple more slides. The question is, again, why cuffless FDA cleared ABPM is the future. It makes 24-hour BP scalable and universal. Every patient can get it. It's easy, accessible. It's not limited by a schedule on a device that you may have to wait for. And it's small, that any patient can do it. It's not going to disrupt sleep. Captures real world phenotypes, not just snapshots that you would get just in a clinic BP, or even a moment in time if you're measuring it at home. Enables precise, responsive, personalized therapy to really, again, provide the idea is that you provide clinically relevant data that can provide enough information to make clinical decisions. But it also empowers both the patients and the provider with better data and more control over their health. Next slide. So the platform is a cloud-based, HIPAA-compliant platform that can be accessed anywhere. It provides a comprehensive blood pressure report. You get to see the averages for the systolic, diastolic, heart rate, but also the daytime versus nighttime. As Dr. Delgado mentioned out, the understanding the importance of the dipping and be able to see those trends. So you see the nighttime dipping, you get to see the morning surge. You can drill down to look at certain times of day. There's a histograph to be able to look at the ranges that they spent, and also the discrete data. You can look at every single measurement as well. Next slide. Obviously, an important topic, reimbursement. So ABPMs, the 24-hour blood pressure test, has been under a national coverage decision since 2001. Biobeat is dedicated to ensuring blood pressure monitoring is accessible for every patient. So our system may be eligible for reimbursement under these CPT codes that have been around. And happy to have that discussion further if you would like. Also, the prevalent and relevant ICD-10 codes. It includes the RO3.0 for elevated pressure reading without diagnosis of hypertension, but also the I-10 essential primary hypertension. Obviously, these reimbursement coverages vary by insurance carrier, so please verify this specific requirements with your specific carriers. Next slide. All right, thank you again. Now, time, if you have any questions, please ask. Dr. Delgado, I'll start. We had one that, how often does the Biobeat device measure blood pressure per hour? If you want, I can go ahead and take that.
Yeah.
The Biobeat device is a 24-hour blood pressure monitor. It measures it every 15 minutes. So 4 times an hour, or 96 total measurements in that 24 hours. We have a question from Joel. What has been your experience with the Biobeat wrist device? It's another device that we have. It is different than just the ABPM. Joel, we can follow up with you and answer that question after the webinar as well. Are any contraindications? Patients with pacemakers or atrial fibrillation, okay? Also, can we use with a CPAP? Dr. Delgado, any experience with those patients?
Oh, yeah. Yeah, definitely with a CPAP. No contraindication with pacemaker or atrial fibrillation. Honestly, the only contraindication that is not a contraindication is to have a mobile phone very close to them during the 24-hour. But no, I have patients actually that, interesting enough, they go into a plane, so they kind of manage with the Bluetooth in the meantime, and then while they go through security, but there's no contraindication. And actually, I encourage you that if your patient has a newly diagnosed sleep apnea, to do the ABPM both before they get the solution, like a CPAP, and after, and you will see the significant dipping related to correction of a sleep apnea.
Thank you, Dr. Delgado. I'll add probably the one contraindication is over a tattoo. So the device uses PPG technology, photoplasmography, for the measurement. And so if they have a tattoo right at the site of placement, that likely you'd have to go over to the other side of the chest. You can go contralateral as well. So that would be the only major contraindication. All right. So are there restrictions? Can it be used with children under 18? The device has been studied in a population of 18 and older. So currently it's on label for patients, adult 18 or older. It would be off label. It is not indicated for patients under 18. Get a lot of people saying thank you. Appreciate that. Does the FDA approval include 24-hour ABPM or just ABPM? So the nice thing, this sometimes can just be the semantics of the words we use. So specifically, the FDA is approved, or the CPT codes through CMS are specific to a 24-hour ambulatory blood pressure measurement. And so it is specific to that 24 hours. It's a retrospective test, not live. And yeah, it is definitely including that 24 hours. How well with different skin pigmentation? Dr. Delgado, experience in different skin pigmentations.
Yeah, Miami or Miami-Dade here in Florida, we have significant amount of blacks, Hispanic, both white and blacks, Asian. There is no difference at all. We have very good, there's no particular insight regarding their skin color. Little complaint sometimes is they need to shave the chest. So guys are a little bit, oh my God, I have to shave. But other than that, no relationship with skin color.
Thank you. Yeah, and Biobeat, the device has been studied in patients of different skin color, also gender and BMI, and there was no difference in the different demographics. Good question, Dr. Delgado. How has this changed patient outcomes as you look at maybe the population that you've used Biobeat with, or the cuffless blood pressure device with?
So the way it changes outcome has to do with being able to understand what is the behavior of the blood pressure and what the intervention is actually doing for your patient. So when you do that, and you can actually reduce, not only reduce blood pressure, but reduce the anxiety related to blood pressure. Everybody has that patient that is very worried about systolic going to 200 and all that. When you show them the reading and the display, you can, both the patient, so it's actually a both direction, the patient and the physician understand. So the outcome is obviously related to the intervention. So your intervention is what is going to direct the outcome. However, looking at how your intervention affects physiology of blood pressure, because what you're actually seeing is physiology when you look at the variability. That is actually a very, very thorough understanding of treatment. So the outcome for all of us is controlled hypertension as the first layer, right? Second and third is avoid or prevention of target organ damage, stroke, heart disease. But that layer that we're still extremely deficit, which is controlling our patient, that significant improve because we can direct treatment according to physiology of or variability of the blood pressure. Obviously, the story is not just treating or responding to the variability. There's other things related to the patient biochemistry. And we actually do a very thorough profile. But just looking at the physiology, you can understand where are you? Are you controlling nocturnal blood pressure? Is the patient well controlled during the day? That is significant. So when you translate this into public, right, public health for us, here in the United States, we have what we call the American Heart Association, American Medical Association Target Blood Pressure Program, which, they awards the clinic, the hospitals, the institutions that have very well blood pressure control. And we have been able to achieve what we call the maximum award, which is Gold Plus for blood pressure control. So in that sense, what I'm trying to tell you is that you're going to grab knowledge that otherwise it will be very difficult to guess within the noise of sympathetic tone, reactivity, and visit, patient's anxiety. Within that noise, it's very difficult to understand what are you doing right or what as a physician you're doing wrong. When you look objectively to physiology and to blood pressure variability with the heart rate, you'll see something different. You will understand.
Dr. Delgado, thank you. The question on how does the data from the Biobeat platform integrate with the patient's EHR, your facility's EHR, the health record system?
So it's integrated with Epic. So we have Epic. So that's the way it's integrated. How is through IT and Biobeat both together managed to do this integration. And as I said earlier, right? Sometimes at the time of visit, the patient comes with a printout, very proud. Look how I did that. And that's actually a blessing for them to see blood pressure control after all their efforts and look at it. So
Thank you. I had a question on skin irritation. Have you seen episodes of skin irritation with the device?
um very few. I will say in the last year, probably two, with a little bit of irritation, which these are patients are highly allergic, and they will tell you, for example, those who know what Cyopatch is, which is the a similar patch that lasts for 14 days for heart rate evaluation. They can't stand it for more than 3 days. So when we tell them this, and this is just one day, they can actually deal with it. But there were at least two patients that had a natural reactivity that they have to any patch. So, but they were able to undergo the 24 hours without problem.
No, thank you. Yes, Bobby utilizes a medical grade adhesive, similar that you would find on a Holter monitor or an ECG type patch. So you would expect her to see if they have severe sensitivity. They may see some redness, but to Dr. Delgado's point, it's a very low percent that we see. Um, let's see, if the user is out of Wi-Fi or Bluetooth, will readings drop or they pick back up? So there is a memory on the device itself. So if there's 4 hours of memory currently on the Biobeat device. So if they're away from their phone they go for a walk, but come back to it, that data will not be lost. We don't like to typically inform our patients that they have 4 hour memory available, because then they'll take advantage of 6 or 8. So, I think it's best, obviously, to always make sure the phone is around. There is an alert question about bad readings. If the signal has gone bad with the device itself, there will be an alert in the app, just letting the patient know that there may be something they need to do to either reposition or maybe it has pulled away from the skin a little bit, that it'll at least alert them that. Also, with the clinician in the portal that they utilize, the dashboard, if they're checking it, there would be an alert in there that the patient is having a bad reading. They potentially could contact that patient. But if you look at the data, we're 98% success rate. And the ones that maybe do have an issue is typically that maybe they close the app on their phone, the phone power died, the device had either been moved or taken off for a period of time. So, not to say it's always user error, but there's usually an explanation of why maybe there was a bad reading. But the nice thing is, again, 98% success rate. So we are able to collect good quality data. Question on if the patient doesn't have a phone, Dr. Delgado, on your experience on one, how often does that occur that they may not have a phone? And then what do you typically do if that patient doesn't have a phone?
So remember that the most important is the patient wellness, right? Ideally, because of the comfort, we want every patient, if possible, to get a patch, and which is what we're using more. And this is through internal medicine. But there will be a good, I will say 1% of patients that they're always in the elderly, right? Very old, 80, 85, 90, that either don't use a phone or or if they have a phone, they have just a phone for phone calls, not for to download or for Wi-Fi capabilities or Bluetooth. And so what we do, we tell them, well, we can't put a patch. We have to do the regular cuff. So we still use the regular cuff. It's just that we use probably out of 100 patches, we do 2 or 3 cough that in those conditions, patients basically it's not even the insurance, because insurance is the same for both. It's the fact that they don't have the phone. So like our elderlies, right? They either live alone, unfortunately, but if they have a caregiver, it's the caregiver's phone. So always the dilemma is, they even the daughters say, well, I'll give him my phone. So what are you gonna do? I mean, your phone has to be with her all the time, and it's always complicated. Some will do it. Will somehow put the phone close to their mom or dad, but very, very few will be into that category. No, we haven't, because I read the question. Not yet. Maybe that will happen in the future, where if a patient doesn't have a phone, we can give them they can borrow a phone just for the connection, and then they have to bring it back. But again, they have to bring it back. So
No, thank you. Actually, a question. This is a good question. Have you published your findings, or are you planning on publishing your findings?
yeah, we're planning on publishing our findings, at least from our center, from the hypertension center. So both in the American Heart and actually papers with publication. So not only presentation at the American Heart, but also publication, hopefully by the end of the year. And
Thank you.
remember, these are not clinical trials. These are findings of the real world, right? Observational. So what is happening to us and what are we done? So which is very interesting, because normally with ABPM, when you get data, it's from clinical trials, because nobody do ABPM in clinic. This is real world, where we did and we are doing on routine basis many, many, many patients. And then we have data to share with all of you.
I have a very good question. What message would you give your physician peers who are not currently doing ABPMs to look at or add to their routine practice?
So basically, the blood pressure is not a single number, and it's not hypertension as a disease. It's not just a number, right? It's a dynamic that happens through the body, and the ABPM is one tool that will help you understand blood pressure. And in any provider that sees patients, at least 50% of those patients coming through your door will have hypertension. And it's very frustrating, because most of those 50% of your patients will be uncontrolled. And how to deal with understanding, okay, if it's uncontrolled, because what is happening that it's making your blood pressure uncontrolled? It's just you coming here and your blood pressure going to 180? Is it something that physiologically throughout your day is affecting your blood pressure? That's the question that you can answer. And the second one, which I think is the most important, is to be able to track the results of the interventions that you're doing with a patient, both pharmacological and non-pharmacological. And as everybody knows by now, there's a third layer of treatment for hypertension, which is renal artery denervation. So that even supports the the reason to make ABPM a routine study, to look, to diagnose, to monitor. You start a patient with a beta blocker or with the ACE inhibitor, you want to see what happened 4 weeks from that date, or 3 months from that date, after you told them not to eat sodium, to lose weight. That change you can actually objectively see. And the patient not only will be happier, but he will be healthier, and you and your patient will both be preventing events or cardiovascular events related to sustain and control hypertension.
Well, fantastic. Thank you so much. At the moment, we've answered all the questions. Really appreciate everyone's time. Dr. Delgado, thank you so much for providing that information. to our audience today, and everyone for joining us. Thank you so much for joining. Feel free. I put my email, I think, in one of the questions. So if anyone wants to reach out, have any additional questions about Biobeat themselves, or if you have any follow-up questions, don't hesitate to reach out to us. And info@biobeat.com is obviously another great option as well. But again, thank you for spending your Memorial Day with us, and looking forward to hopefully speaking with some of you in the near future.
Thank you. Thank you very much.
Thank you very
Dr.
much.
Delgado. Thank you, everyone. Thank you very much, Jay. Arik is also with us. Arik is the CEO of Biobeat.
Hi, everyone.
So a couple of words from just Arik, and then we're off to our day-to-day. So
Just want to say thank you to Dr. Maria Delgado for taking the time to speak with us and, of course, share with us her experience. And, of course, thank you very much to Jay and Sharon to organize this amazing webinar.
Thank you.
thank you very much. Have a good evening, everyone.
Bye-bye.
Bye-bye.
Bye-bye.